It is my proud privilege to welcome and request Professor Dr. Sarita Bajaj, former Professor and Head Department of Medicine, Evelyn Medical College, and renowned endocrinologist of the city, for the scientific deliberation, a role of endocrinologist in management of thyroid disorders. Dr. Bajaj, ma'am.
Your camera? Anjali, can you give your camera?
Good afternoon, everybody. Now, our next speaker is Professor Sarita Bajaj. She is ex-former Director, Professor and Head Department of Medicine, MLM Medical College, Prayagraj. At present, she is President, Indian Thyroid Society. She was President, RSSDI, former Founder President of South Asian Federation of Endocrine Society. Then she is Editor-in-Chief of ESI Manual of Endocrinology, and she has delivered so many orations and publications. There are several publications to her credit. Now I request her to deliver her lecture on the role of endocrinologists in the management of thyroid disorders.
Very good evening to everyone. Thank you, Dr. Sinha, respected chairperson. And thank you to, of course, Anubha for this invitation. Thank you to Allahabad Medical Association as well. So I hope I'm able to finish in the allotted time, and I definitely will try to do so. So I think the topic is very clear. What I plan to do is to take you through some cases which will perhaps highlight how varied the manifestation of a very, very straightforward disease for which we have just one drug. I will be basically focusing on hypothyroidism, but just to give you an idea as to how well or how poorly one single drug can be managed. So perhaps you think that as an endocrinologist I have a tunnel vision or tubular vision, but at least let me see if I can make a difference over there. So, like I said, I'll be focusing on hypothyroidism, and because hypothyroidism may or may not be associated with a goiter, so I've just highlighted goiter there as well. Primary, secondary, extremely common. I've given you the prevalence over here, but remember that what we use as thyroid medication today, which is T4 or levothyroxine, is available in the current form only since 1970. Okay? Before that, we were using desiccated thyroid extract, which was a crude mixture of T4, T3, even that was not very kitna T4, kitna T3. It was that bad. And before the year 1880, what happened to patients who had hypothyroidism? Just like diabetics, before a century, before insulin was discovered, what happened? I think the answer is mentioned here. They just died because hypothyroidism is life-threatening. I think that's a very important message that I want to convey here. I always like to talk about this family and wonder if this pointer is working. It doesn't matter. It is? Okay. So this is type 1 diabetic. The sister is hypothyroid. The the father is also hypothyroid. So what happens is, there's lots to follow. I haven't seen them for almost 2 decades now. So the mother gets burnt in the kitchen. She dies. The father stops taking his hypothyroid medication. He dies. So now these children are orphans. That is the last I remember of them. being brought up by their grandparents. And the other point that I wanted to emphasize here is that hypothyroidism runs in families, as do endocrine disorders, like you can see type 1 diabetes here, and which is autoimmune, and usually hypothyroidism is autoimmune as well. A host of symptoms and signs, I'm not going to go into details, is very standard. The only message here is many patients with hypothyroidism, even overt hypothyroidism, may report no symptoms at all, and the accuracy, its symptoms and signs are non-specific and occasionally quite insensitive. It depends on the duration, the severity, the rapidity with which hypothyroidism develops. New and persistent symptoms occurring in combination are more likely to be relevant. Again, a lot of laboratory and radiological features which are also supporting. But now I will move on to the individual, like I will be taking you through different cases of adult hypothyroidism, juvenile hypothyroidism, cretinism, and a little of mixed disease as well. So this is a 30-year-old woman. She has no symptoms of hypothyroidism. Her T3, T4 are normal. Her TSH is marginally elevated. What would you like to do? Would you like to wait and watch? Would you like to retest, check antibodies, or just start treatment straight away? I wish I could interact more. How many here are just physicians for sure? Physicians? Hands up. So this is a mixed crowd. So I have to be very careful with what I say so that we're all on the same page here. So anyway, anybody from the physicians, what would you like to do? Okay, so when we look at the type of TSH assays over the years, now we have most labs today are doing really the sensitive assay. So a repeat TSH done in a separate lab with a third generation assay, it showed an absolutely normal. So what was the answer here? You would retest, and yes, you would also check antibodies. I'm not talking about antibodies, why, how much, when, what, etc. But this is the most logical approach. She's 28 years old. She's asymptomatic. She's married. You can see I've highlighted the T3 is raised, the T4 is raised, the TSH is normal. What next? She's not pregnant, but she's on oral contraceptive pills. So these are the conditions which affect the binding of TBG, thyroxine binding globulin, and oral contraceptives is one of them. So a good history taking is important if you need to know what is the cause of elevated T3 and T4 with a normal TSH. As a rule, the teaching is that TSH alone is enough to make a diagnosis of hypo or hyperthyroidism. So that is why we would do a TSH, but most people do bring the reports of T3, T4 and TSH. So then these are the sort of reports that you have to interpret. She has gained 20 kilograms, she's tired, thinning. These are typical features of hypothyroidism. Of course, she's overweight, there's no doubt about it. The skin is dry, thin coarse hair, she's bradycardia, bilateral carpal tunnel syndrome, delayed. This typically, this is a classical picture of hypothyroidism. You can see her TSH is whopping, it's really high. I told you that I mentioned in a couple of slides earlier that we do TPO antibodies. Yes, TPO antibodies are positive. So what is her diagnosis? It's primary, it's autoimmune hypothyroidism. She was started on levothyroxine 100 microgram and her thyroid profile became normal subsequently. But she is stuck on that 20 kilograms of weight gain. And what do I tell her? What should I tell her about the 20 kilograms of weight gain? So I'm just holding that for a minute. I'm going on to the next case, who's 29 years old. She's also taking 100, I'm sorry, that should be unforgivable. It should be 100 micrograms of levothyroxine. She's frustrated, she's gaining weight despite regular exercise, is tired throughout the day, poor memory, work performance, she's obese, her thyroid profile is normal. So what would you do? Would you continue the current dose of levothyroxine? Increase the dose? Remember I told you about desiccated thyroid extract which was being used once upon a time, which contained T3 and T4. So now we are going back about 60 years and again talking about giving T3. So would you like to add the T3 twice daily and reduce her T4, or replace the T4 with T3 as a single therapy? So I'm making it more and more complicated for you, isn't it? So more and more choices here. Again, I'm not talking about this case. I'll come back to this case later, but just to give you a hint of what is in the pipeline or what we are going back to from what we were having earlier. But going back to the 20 kilograms of weight gain. Obesity exists without hypothyroidism. It can mimic most symptoms of hypothyroidism, and obese people who also are hypothyroidism will have a crutch for the rest of their lives that I cannot lose weight because I'm hypothyroidism. But hypothyroidism does not cause morbid obesity. So if she has gained 20 kilos, she max, even with that high TSH, she would lose 4 to 5 kilograms, that's it. 15 kilos is her own burden which she has to lose. So I've answered that part. The second part, T3, T4, alone T3, I'll be coming to subsequently. So, okay, so now the TSH is normal. I told you 2 patients in whom the TSH was normal, but you can have a normal TSH, yet the symptoms of hypothyroidism are still persistent. So these are the causes here which I've tried to list. Anemia is important, B12 deficiency, iron deficiency, chronic kidney disease, depression, anxiety disorder. These are very important. Adrenal insufficiencies where the others are also not so common. But what is important? So if your TSH is abnormal today, it was normal earlier, then what would you think of? In other words, it has been normal for quite some time, but now all of a sudden it's going up, or your patient needs an exceptionally high amount of levothyroxine. The average patient settles with around 100, just give a few milligrams here and there. But 250, 300, 400, 500, I'm talking of those many microgram. So the most important every time, in fact, every time I want to put one slide with 10 bullet points which say compliance 10 times over. Because you really have to check compliance. But I've also listed the other important things like medication handling, storage. Ideally, one should not substitute the brand. They should continue on the same brand. Reliability of the preparation. Pregnancy, I've just given you an example of OCP intake. HRT, celiac disease is a very, very important cause. Malabsorption of levothyroxine per se, other medications, spurious medication, and morbid obesity, because as you gain weight, when we talk of the dose, it is weight related, the dose will be weight related, so maybe the dose increases there as well. This was circulating, so this is why I brought it up. Yes, there are spurious thyroxine brands which are also being marketed, so you have to be careful about that as well. Now she's 34 years old, she's been married 6 years, she's a known case of hypothyroidism, she has had 3 miscarriages. Her TSH refuses to come down. from 80 to 34 to 68 to 23 to 12. It just refuses to come down. So what is the answer? I've given it to you earlier. Nobody? Anyway, I wish it was so straightforward. I would love to say compliance, but this is not the answer here. She was regular with the medication, she was taking a reliable brand, she was taking it properly, but what did I tell you? One cause? Celiac disease. So this is a marker of celiac disease. The transglutaminase was very high, cortisol was normal, calcium was a little on the lower side. After 3 months, she was put on a gluten-free diet. Everything is normal now. So yes, there are other causes which need to be considered as well. Hypothyroidism in the elderly, again, what did Dr. Chintamani say? 55, American Thyroid Association as far as the elderly is concerned. But actual definition is over 65 when we really talk of the elderly. Symptoms and laboratory data may be very confusing, it's very difficult to say, and over the age of 85 we actually do not know. Marginally elevated TSH is believed to be good for longevity as well. So for elderly, it's better to refer. Juvenile hypothyroidism, the most important thing to remember here is that the developmental retardation will not be severe, but there will be a severe retardation of the linear growth and permanent teeth, delayed puberty. Rarely you can get precocious puberty. I remember a 3-year-old girl with severe hypothyroidism, and she started menarche. 3-year-old girl coming with menarche only because of hypothyroidism. You can have galactoria, poor, not so much intellectual, performance, because the school performance goes down. So parents will come and say, my child is good, I mean maybe intelligent, but all of a sudden there is a deterioration in that. And the bone age is, I'll tell you what is meant by bone age. So this is a 19-year-old boy standing next to his 17-year-old cousin. You can see how severely the height is retarded. And I always say, anybody who comes to you with short stature, it is criminal not to get a thyroid profile. So many are missed only for not getting it done, whereas otherwise left, right and center people are getting thyroid tests done. Again, another juvenile hypothyroidism. This is what I meant by bone age. So chronological age is your age right now. But if I take an X-ray, the X-ray is taken off usually left hand wrist, including the wrist, because the non-dominant, left we take because it would be considered non-dominant. I rarely ask, are you non-dominant right, but conventionally it's left, so we write that. So we write, we get a bone age. And if you look carefully, you can just see 3 carpal bones, yes or no? Right? So the bone age of a 12-year-old is just 3 years. Can you imagine how severely the height is retarded here? And believe it or not, 1 year of thyroxine and all the carpal bones would have come back. It works so dramatically. But will the child actually attain the final height which would have been attained if the child had been diagnosed? So the earlier the diagnosis, the better the outcome as far as height is concerned. This is another very interesting case. So this is another very interesting case of polycystic ovaries. Huge polycystic ovaries, severe hypothyroidism with galactoria. And I know of girls who have, because of these huge polycystic ovaries, they've been cut. So what happened? If you cut off the ovaries, surgically remove the ovaries of a 13-year-old, where have you left her? And the diagnosis here is hypothyroidism only. Everything will reverse. So if you see polycystic ovaries, please think of hypothyroidism as one of the causes. And please do a thyroid profile. Everything will go back to normal. Because the child comes with one ovary out and the surgeon is ready to take out the other one as well. So please, whenever it's polycystic ovaries, think of hypothyroidism as well. So anyway, this is the biochemical corroboration, and actually this patient was referred as a case of carcinoma ovary for endocrine clearance for hypothyroidism. So this is now being thought of as ovarian cancer, all ready to go under the knife, but she was started on T4, everything went back to normal within 5 months. So this is well described, this Van Wyck-Grumbach syndrome due to chronic uncontrolled juvenile hypothyroidism. Any guess on this child's or baby's, infant's thyroid? TSH. Any guess on the TSH? Nobody? 1,000 plus, a little over 1,000. This is, I'm talking of 1992 when I was doing my DM in All India Institute. Coincidentally, the family was from Allahabad. The patient's mother kept on telling her mother-in-law that my baby, something wrong with my baby, something wrong with my baby. But the mother-in-law was not sure about it. So anyway, so by the time the child is diagnosed, it's 9 months late. So what will happen? There will be mental retardation for life. That is what we call cretinism. So cretinism is hypothyroidism present at birth, and it should be diagnosed at the earliest possible. Every single day lost is resultant mental retardation, absolutely preventable cause of mental retardation. This is a 4-year-old child who still cannot sit, That is how severely retarded he is, even, of course, as far as physical development is concerned. So maybe very few symptoms or signs. It should be, all children should be screened. So all newborns should be screened, but we do not have the resources for that. And this was started in '63. You can imagine how way back, how we are just not there right now. And this was published in the Lancet that yes, India launches program for child health screening, but believe it or not, even that did not include screening for congenital hypothyroidism. It's really, really very important to start it. And as president of the Indian Thyroid Society, we are trying our best. But every state has its own laws, which are different, and it's going to be, I think, almost next to impossible, but one can only try. So these are the features of untreated congenital hypothyroidism. So that's it, coming back to another case. 40-year-old, tired, weight loss, palpitations, lethargy. What are the differentials here? We have a TSH which is normal, a T3 which is elevated, and a T4 which is elevated as well. So you would think of TPG abnormality, resistance to thyroid hormones, and a TSH secreting pituitary adenoma. So these are some of the difficult cases for which you would definitely need specialist consultation. So again, I'm not going into the details of those. Sorry, yeah. So these are lingual thyroids. So you know when the thyroid descends, so it may not descend, or it may go way down into the chest as well. So that is what happens. That's what Dr. Chintamani was trying to show you, the thyroids that are sitting right in the chest as well. So, but remember, any thyroid which is not in its normal position is dysfunctional. It's not working normally. So the patient is going to be hypothyroid. So what you see here is lingual. So you just open the mouth and you will see a thyroid sitting there. So these will be hypothyroid individuals. So now this is a 21-year-old lady. She has altered sensorium, no history of fever or rash. She's hypotensive, random blood glucose, she's hypoglycemic. CT head is normal, CSF is normal. She has a low T4, low T3 with a normal TSH. What else do you want to know? Okay, is she menstruating? No, not since the last 5 years. Secondary amenorrhea after second delivery 5 years back. Postpartum hemorrhage, yes. Was she able to lactate that child? No. Yes? The answer is coming. Very good. Wow. I think you've done wonderfully well. Thank you. So my job is done. I can leave the podium. So anyway, Shihan's was confirmed and she was started appropriate medication, and I think thank you for that. But preferably refer. Preferably refer, please, because these patients need to be started corticosteroids. You do not want to increase their metabolism with thyroxine, then they go into adrenal failure, and so on and so forth, and you're going to get a very sick patient on your hands. So this is the patient. Remember I said I'll come back to? Okay? So she's 29. She's well controlled on 100 mcg. I didn't correct it in that slide. I corrected it in this one. She is gaining weight despite regular exercise. She's tired throughout the day, poor memory, work performance. She's obese, thyroid profile is normal. And then I asked you, do you want to continue LT4? You want to increase the dose of thyroxine? You want to add T3? Or you want to stop T4 and give her T3? So now I'm answering that question here, that despite achieving euthyroidism, our patients are sometimes just not happy. So how do we get them to become happy? So as far as levothyroxine is concerned, it is one of the most widely prescribed drugs today. Number 1 in the US, number 3 in the UK. So if there are patients who are not getting better on monotherapy, then we consider adding T3 as well. But just remember that who should prescribe? It should be done under the observation, it's under strict observation and under a specialist. When you add T3, it's not a joke. You have to be really very careful and you have to be absolutely sure. It's not कि बस इसको भी खिला दो तो बात बन जाएगी. I'm sorry, that is not the way it works. Severe hypothyroidism in pregnancy. So we have 2 patients here, 22-year-old lady, primary gravida, 14-week pregnancy, TSH 61. The other one is 34 years, which is what we are seeing more and more these days. Treated for secondary infertility, IVF pregnancy, TSH 42. So Pankaj will take over from me and he's going to answer this question. So that's what the patient is asking you. I'm not sure what the gynecologist told her. Maybe she's scared him quite a lot to continue or to terminate the pregnancy. Yes, Pankaj, you ready to come on? So I'll end up now by telling you that who should be referred to an endocrinologist. All children and infants. I gave you examples. Elderly. Unusual constellation of thyroid function tests. Patients in whom it is difficult to render and maintain a euthyroid state. In other words, patients who are unresponsive to therapy. If you suspect myxedema coma. Then I gave you examples of secondary hypothyroidism like Shihan's. If there is a goiter or a nodule or other structural changes in the thyroid gland, thyroid hormone resistance, if there are other endocrine diseases associated like adrenal and pituitary, unusual causes, when I gave you that list of agents which had the OCP in it, all pregnant women, and even if they are planning pregnancy, there's no harm if they have underlying cardiac disease. Evaluation for suspected hypothyroidism, yes, even in the algorithm in the textbook it says, okay, go ahead and have an endocrine consultation. If anybody can answer this question, I'll be so happy. Like I said, there's only one drug and this is how it is managed. I hope this is not a student of mine and this person is not sitting here in the audience either. She's a 25-year-old housewife, recently diagnosed, September 2021. So what would you call this? What is her diagnosis? She has a low, my last line. Am I allowed to continue? So she has a really low TSH with a high free T4. So what is the diagnosis? hyper. And then what did she started? Levothyroxine. I don't know who started levothyroxine. I just for the life of me couldn't understand. And then the second report is more hyper. Then the doses increased to 125. Third time when the patient also understood there's something wrong with my reports, which the doctor is something fishy going on. I hope this was not an Ayush person. You never know. Yes, it's quite possible. But anyway, so then the patient came back to me the third time. What would you have done? We're not talking hyper here. We're talking of actually when the treatment can go so desperately wrong. Thank you. Thank you very much.
Would the chairpersons like to say anything?
Thank you so much, ma'am. It's an honor to be sitting here and listening to you, having been taught by such a nice day here when our teacher and students are here to speak as speakers and faculty. And really honored to be a chairperson with Subodh sir, GC sir, and sir, Vineet sir here. And thank you so much, ma'am, for delivering us such a wonderful talk. The house is now open for questions, if any. Thank you so much.
No questions? Let's wait. Ma'am asked all the questions. Ma'am has already asked all the questions. I will request Dr. Sujit Singh. Yeah, sorry.
Yeah.
First of all, I want to congratulate you.
Thank you.
Ma'am, such a nice case-based, very interesting presentation. Madam, I first time heard about T3 giving. So is it available in India?
Yes,
We
it
will
is.
refer to endocrinologist.
It's coming just around the corner. That's why that was a teaser. But then I've already warned everybody here not to touch it. It's for me only.
Yes. Thank you.
I will request Dr. Sujit Singh to kindly give away the certificate and the memento to the speaker, Professor Bajaj. Chairpersons, please join us. Thank you. I will now request Dr. Sujit Singh sir to please give away the certificates and honor our chairpersons. Dr. GS, Dr. Subodh Jain, Dr. Vineet Agarwal, Dr. Piyush Saxena. I will now hand over the reins of the session to Dr. Pallavi Nigam. Thank you so much.